So I'm going to get started with that. So you'll have slides. You'll also have some tables and charts where all the medicines are consolidated in an easy way to compare and contrast. And you'll also have a soap note of this case that we're presenting. So you can look at that from your either on the slides, or if you want to handwrite on your notes, they're in the charts and tables. Okay. Testing. Very good. All right, for those that came in, we are going to be role-playing a person in the emergency room having migraine headaches. You can take notes on your slides, or you can take notes on a soap note that's written in your supplemental handouts with the tables. Okay, so we're going to begin. And this is Phil, who's a graduating student, and he's going to role play a non-rotation.
Hi, my name is Phil. I'm a pharmacist here today. So what brings you to the emergency room today?
I have this really bad headache. I threw up at home, and the headache go away. I feel really sick.
Okay. So when did these symptoms begin?
Well, I went to bed last night really early. I've been working really hard. And I thought I was just getting the flu. And I was really nasty to my husband. He says he just got mad at me and says, "You just go to bed, you're irritable." Well, so I woke up this morning and I couldn't see right. And I have this odd feeling in my hand.
Okay, can you describe that feeling you're experiencing?
Yeah, it's just like there's these pins and needles and really, really tingly.
All right, what happened next?
Well, this lasted about 40 minutes, and then my headache, this unbelievable headache started. It wasn't too bad at first, and then it just got slowly worse and more worse, and I threw up my breakfast, and my head pain got so bad. My husband drove me here. He's trying to park the car now.
Okay, so I see you, moving your hand around your forehead. Can you kind of show me where the pain is that you're experiencing?
Yeah, it's right here, right by my eye and on my temples.
Can you describe the pain for me?
Yeah, it's throbbing and pounding, it's pulsating. And can you stop talking so loud?
All right, I'm really sorry. I'll try and lower my voice for you.
Yeah.
Can you, if on a scale of 1 to 10, 10 being the worst, how would you describe the pain?
Oh, an 8.
An 8, okay. Do you have any other symptoms that you're experiencing?
Oh my gosh, it's so bright in here. The light bothers me, and I can't see things clearly. Part of your face is missing, and nothing's clear, and oh gosh, my mother died of a stroke. Do you think I'm having a stroke? Oh my God.
All right, just calm down for a few minutes. Just a few more questions. I'll try and figure out.
Gosh.
Have you had any other symptoms before?
No. Can you just stop asking me big questions? When are you going to give me something for the pain and
Have you had
the
any of these
nausea?
before?
No, I never had these like
Do you have
this
any
before.
other conditions?
No, I'm healthy. Just a
Do you take
workaholic.
any medications, herbs? supplements?
No, don't you have that information? They took so much information when I came in here. Who are you?
Do you smoke? Do you drink alcohol? Do you use
No,
drugs?
no.
I'm just trying to figure out, anything that could aggravate the headache
No.
that you're experiencing.
No, well, I drink about 3 to 4 cups of coffee, but I ran out of coffee a couple of days ago.
Okay, that's important. Caffeine, could affect that.
Yeah.
So, is there any possibility you could be pregnant?
No, I started my period today also. Oh my God, I just feel so sick.
Alright, so now, so I collected her vital signs and I performed a mental and physical exam, and now I'm going to go find the attending physician to talk to.
Oh my goodness, what happened to you? You need a new coat. And your shoes? Oh my goodness, we have to go clean you up.
It's like, that might need to change, but anyway, so, so I just spoke to S.H. She's a 130-pound woman, 5 feet 5 inches tall, and I want to order some tests for her because I think she might be experiencing her first migraine headache.
Okay, what kind of test do you think you'd like to have?
So I'd like to order an MRI just to rule out that she doesn't have a stroke, because she told me that her mother had a stroke, so maybe she has a family history. We would also want to rule out some structural abnormalities, although she doesn't have any risk factors for an embolic stroke, such as hypertension or a smoking history. So it seems unlikely that she's experiencing a stroke right now.
What risk factors might she have?
She does have, some visual and neurological symptoms that seem to be associated usually with migraine symptoms. And
so the only history she has is really as a mom that has cardiovascular.
Exactly.
But she's healthy, no hypertension.
Yeah, she seems to be healthy as of right now from what I got from her.
And what do you think these visual symptoms are that she has?
So I think that's associated with migraine symptoms.
Okay.
But she doesn't have, I also did a neurologic exam. It doesn't seem like she's having any signs on that exam.
Okay. So all her cranial nerves were intact.
Exactly, yeah.
Okay, good. Okay. So what symptoms does she have that fits the migraine symptomatology profile?
So she told me that the headache pain had a gradual onset, including the prodrome. She also told me that the pain is unilateral on just one side of her head.
Okay.
And she described this pain as throbbing, pounding, and pulsating. She's also 35, which is, within the normal range of the first onset of migraine, which is about 10 to 40 years old.
Okay, so those are really typical symptoms.
Yeah, she also has, some visual changes like the photophobia, scotomata, and nausea, which are associated with the aura and then the onset of the headache.
Good, good. What kind of scotomata does she have? What does she say?
Yeah, she says that, she's very sensitive to light. She said it was too bright in here.
Right.
Oh, and she could, she can only see like half of my face.
Okay. So those are pretty typical too. Any other associated symptoms that she has? I'm going off scriptures.
So, yeah, she also experienced some nausea. She said she threw up her breakfast, and as you can see, threw up on me.
Okay. So has she experienced most of the headache phases?
So it seems like she has. She experienced the prodrome symptoms the night before. She told me she was irritable, cold, and felt sluggish. Then it seemed like she had an aura about 40 minutes prior to the headache, and which is associated with the scotomata, and she described that as the partial loss of sight. And she also had the tingling in her hand.
Mm-hmm.
So she's currently in the headache phase, and she has symptoms of photophobia as well as nausea and vomiting.
And do you think she has any potential precipitating factors or triggers that may have led to this?
You know, it's hard to tell right now because there's no pattern of her headaches, but she might have some risk factors. She told me she drinks 3 to 4 cups of coffee a day, and she recently stopped, so maybe she's going through caffeine withdrawal. She also started her period, so that could be related to her menstrual cycle. She also ate Chinese food last night, which is a lot of MSG, so.
Very good, good pickups, yes.
Yeah, she seemed a little anxious, but I don't think it's because of anxiety or depression.
Yeah, it's probably common when you don't feel well, yes. So what medications would you give her?
So the nurse gave her prochlorperazine 5 milligrams IV right after she vomited.
Yeah, that will help.
And then triptans or ergots are the drugs of choice, considering her nausea and pain severity.
Yeah.
So I think we should avoid the oral route of administration because she probably won't be able to swallow it and hold it down.
Very good. Yeah.
So we could use dihydroergotamine 1 milligram IV and then repeat it 8 hours if the headache doesn't improve.
Mm-hmm.
Or we could give sumatriptan 6 milligrams sub-Q and then repeat in an hour if the headache hasn't improved.
Okay. Yeah, all of those are good options. So what are you gonna? Let's go with the triptans, the sumatriptan. What do you want to monitor for her?
So I want to monitor her headache and the pain at 1 hour, 2 hours, and then over the next 24 hours.
Mm-hmm.
And I want to check for any adverse effects.
Like what?
Neurologic symptoms are common with the triptans because that's the one I'm good.
And then it's also going to cause some vasodilation, so some cardiac chest pressure, heaviness. She might have some dizziness and flushing. So look for those two. All right, so it's now 6 hours later, and she's had her medication, and the student is going to come and tell us that how the patient did. So how's she doing?
She seems to be doing pretty well on the medication the sumatriptan.
So what do you want to send her home with?
So I want to send her home with 3 medications: ibuprofen, metoclopramide, and sumatriptan. I would tell her to take the ibuprofen for if she has a mild headache.
Okay.
If it becomes more moderate or severe, I would tell her to take the sumatriptan. Then she could take the metoclopramide if she starts to experience nausea or vomiting. Good.
Okay. And it's real important to tell her to not wait. That was part of the problem she had. She could have taken the Motrin the night before, and as soon as the pain started, she didn't need to really wait. Now that she recognizes these symptoms, the earlier the treatment, the less likely it'll progress. All right. So what would you want to do next?
So I think it's important for her when she goes home to keep a headache diary and record, things about the headaches that she starts experiencing, as well as the symptoms and potential triggers that she has. So I'll go over some of those potential triggers with her. And, for example, in her case, she could evaluate the effect of coffee, the food she eats, and her menstrual cycle, and see if it's related to her headache frequency. And I also try and tell her to minimize coffee use to 1 to 2 cups per day.
Okay. Yeah, the National Headache Society has a really great list here. I'll pull it out for you. You can give her this. It's really
great.
That's helpful. And, just also explain that there's a lot on this list, and some may aggravate her and some may not, and it's going to be a learning experience for her. And in the diary, she's also going to want to pay attention to any lifestyle factors that may aggravate. A lot of patients, you notice that she was a little anxious, and that's also common in patients that have migraine. They're type A people, they're workaholics, they don't have a regular sleep and wake and eat cycle. So it's kind of helpful just to do the lifestyle changes and have her track that. And as she's getting older, she's going to start getting perimenopausal symptoms, and that's going to possibly increase her chances of headaches as her hormone changes. So that was good that you recognized some correlation with her menstrual cycle. Okay, so why don't you go talk to her and, let her go home.
All right, great. I'll go do that right now. Yeah, I'm going to talk to you for a few minutes. I just spoke to the attending physician, so
Okay, good.
just a few more minutes. So we feel like you've experienced your first migraine headache. Your MRI.
Is it bad?
No, it's not bad because your MRI exam indicated that you didn't have a stroke, so that's really good.
Mm-hmm.
So you might have some potential triggers that increase your risk of developing this headache.
Mm-hmm.
It may be the combination or individually that you stop drinking coffee after you've had 3 or 4 cups a day.
Oh, I like coffee. Yeah.
Me too.
Yeah.
You just started your period, and you ate the Chinese food, which might have a lot of MSG, which is also another trigger the night before you started the headache.
Yeah.
So it's important to try and that's why it's important to keep a diary of your headaches, because you can try and see what things aggravated or associated with the headaches that you do. So here's a list of the potential triggers for you.
There's a lot on there.
Yeah. So we'd like you to, as I said, fill out the diary if you have another headache. And it's important, again, to record any triggers you have, as well as when the headache starts, how long it lasts, or when you start experiencing those, visual or other, like your hand tingling. It's important to document when you experience that. And then record how well your symptoms respond to the medications that we give you.
Okay, that looks like it won't be too hard, yeah.
All right, so we're going to suggest 3 different medications for you: ibuprofen, metoclopramide, and sumatriptan. You may not need all of them, but you should have them all.
Can you say
just
all
in
those
case.
names again?
Sure. Ibuprofen, metoclopramide, and sumatriptan.
Now, what's the difference between all of those?
So it's important that you take ibuprofen 600 milligrams as soon as you think you're going to have a headache, and it's important to take it much sooner than later, because it'll work better if you take it more close to the time that you start experiencing any symptoms.
Okay.
And then if you begin to feel nauseous, you can take the metoclopramide, 10 milligrams. If your headache becomes more, moderate or severe in pain, then you can take the sumatriptan, which is actually an injection, and I'll show you how to do that.
Yeah. Okay. All right.
It's also important that you eat a well-balanced diet, as well as take a multivitamin, because some studies have shown that there's an increased risk of headaches if you have low magnesium or vitamin D levels.
Okay, I can do that. Yeah, I stopped taking my multivitamins. I didn't know how helpful they were, but I could do that again. Yeah.
And so, these medications might decrease your chances of coming to the ER.
Oh, that would be good. And,
the other most important thing is that if you can control the triggers, then you might not have another migrane, or your headache might just respond simply to the ibuprofen. Okay.
I'm gonna put down the slide. So anything I need to worry about with the sumatriptan?
It's important not to overuse it. It's recommended that you only use it about 2 to 3 times per week, or 10 times at most per month. Because if you overuse it, then that could also trigger migraines.
Okay.
It's important to balance the use of it.
Okay, so I'll make sure I record every time I have a headache on this diary, and when I take the medicine, and any other symptoms I have during that time. Okay.
Exactly.
All right. Well, thank you very much. You were a good student. Good luck in your career here.
Thank you.
All right. Bye-bye. So that was a sample patient with migraine, where the patient was greeted by the student and presented to the attending, and discussion of what treatment could take place. So it's important, you'll hear through the lecture, that if people overuse the acute medicines, they often will end up with chronic daily headache, which are really, really difficult to manage. So it's important for her to keep that diary and track that, because she might be a candidate for preventative medicines. And if someone's needing more and more acute medicines and they've done good lifestyle changes, that's a marker for whether they need some of the preventative treatments. Any questions before I go and start the lecture and let Phil go? Any questions for Phil, because he's graduating and you're starting to do in his shoes? Because he's going to go over to the senior center to do some stuff. last chance to get advice before rotations? No hands raised? You're dead today. All right. Give a hand for Phil for. Okay. So I know there's a lot of information in those handouts, so what we're going to try to do is guide you through those. Start at the beginning here. So headaches is a great opportunity for pharmacists to get involved with patient education and managing all of the different choices. There are a lot of drug interactions and side effects. There's the rationale for preventative therapy and helping pick those agents. So what I hope to do today is go over the different types of headaches. We have migraine, cluster, and tension. We'll put most of the focus on migraine, how to pick the right agent, and then based on comorbid conditions, and also selecting preventative care measures for these people, and understanding the side effects and safety profiles of these agents. So we have primary headaches and secondary headaches. I have a table in your collection of tables that go through all the different types of secondary headaches, and that's going to be your primary role. If a patient comes into your pharmacy, you're going to have to decide whether it's a medical emergency or not. I was very alarmed. I was in a pharmacy, and the person was saying, I have the worst headache of my life, and they were sending them down the aisle to get Motrin when it could have been a hemorrhagic stroke. So that was pretty scary. So you have to recognize what are a medical emergency for having a headache treated. So some people are afraid to go to the emergency room. Now that we have some urgent cares, people are a little less afraid, but it's important to get people treatment as early as possible if you recognize the secondary causes. We're going to focus on primary headaches, migraine, cluster, and tension. So migraines, some are with aura, some are without. Secondary causes of headache are these: like trauma, strokes, withdrawal from medications, various infections, hemodynamic problems with homeostasis, and various disorders of the head and neck. So withdrawal from various substances such as antidepressants, analgesics, steroids, ergot alkaloids, hormones, triptans, alcohol, caffeine, narcotics, nitrates. So again, a good role for the pharmacist to be able to recognize this. Overuse of headache medications and caffeine will increase the risk of chronic daily headache. There's a lot of drugs, and you have a handout table that lists almost a page worth of different drugs that can cause headache. So I'm not going to make you memorize every single one, but every time you add a new drug to a person's prescription profile, you want to, in a patient that's having headaches, you want to consider whether those are the etiology. So when we look at the patient history, we need to know these criteria in terms of helping define the treatment plan, in terms of where the onset is, like is it gradual, the actual location, the severity type, how frequently are these attacks happening, how long do the attacks last, are there any other associated symptoms, can we recognize any triggers, what makes it better, have they used other drugs in the past and how have they worked, what are their sleep habits, family history, comorbid conditions. There's a lot of associated lifestyle factors that come into play with migraine. When I have worked with the migraine specialist at Robert Wood, what we usually see there, again because it's a tertiary referral center, is we see people that are refractory patients. And so most of his patients are people that have chronic daily headache because they haven't corrected lifestyle factors and ended up overusing medication. So a lot of what he does is he'll do a diagnostic workup with the MRI and other laboratory tests, and he'll make them try a 1 to 3 month period of time without medication, just working on lifestyle changes, because he feels so confident that it's the lifestyle that aggravates a lot of these migraine headaches. Type A people that don't have regular and good sleep habits, and as one gets older, they don't have the compensation mechanisms to counter. So these are the various laboratory tests that we will collect. So the epidemiology is that it's a combination of headaches, the light sensitivity, sound sensitivity, nausea, and those who experience more than one migraine headache per year are what we define as that. And it occurs more in women than men, and usually people have had their headache at least by age 30, but the range is 10 to 40. The distribution and description is throbbing, pounding, and pulsating. Usually starts on one side and then can become bilateral. This usually is not like instantaneous, like what you saw with the baseball player, like he's throwing great pitches and then he goes into the dugout and he collapses with a subarachnoid hemorrhage. Usually for this it's a gradual onset. They may have a prodrome that proceeds up to 24 hours beforehand. 20 to 25% of the patients may also have an aura that precedes and also accompanies the headache. So there are at least 5 criteria that need to meet the criteria, at least 5 attacks that fulfill these criteria. So the headache has to last at least 4 to 72 hours. The headache has to have at least 2 of the following. It has to be unilateral. These are the symptoms that we just talked about. It has to be pulsating in quality, moderate to severe intensity, and it has to be aggravated by avoidance of routine physical activities such as walking and climbing stairs. So aggravated by physical activity. So you have to have at least 2 of those factors. And during the headache, you have to have at least 1 of the following: associated nausea, vomiting, sensitivity to light and sound, and you can attribute it to some secondary cause. You have to have at least 2 or more attacks that fulfill the following criteria, more than 1 of the following that fully reversible aura symptoms, and these are symptoms that people may have as part of their aura: visual, sensory, speech and language problems, motor problems, things that occur through the brainstem and eye system. Greater than 1 of the following 4 characteristics, at least 1 aura that spreads gradually over 5 minutes, 2 or more symptoms that occur in succession, and these symptoms last 5 to 60 minutes, and at least one aura symptom is unilateral. So we have patients with aura and without aura, and these are the ones with the aura. So these are the phases that we talked about in the sample case. We have premonitory phase, an aura phase, headache phase, and resolution phase. So this prodrome or premonitory phase, these are the types of symptoms that the patient may have. So example, our patient that we presented today, the night before, she was irritable, she didn't feel well, she was tired, and that occurred before the headache phase. And that occurs in 12 to 80% of people. Again, only 20 to 25% of people will have an aura, so it's not everybody. And these are symptoms that come 5 minutes to 20 minutes before the headache, and can last up to about an hour and can go in through part of the headache phase. The headache phase, the patient has the headache, but they also may have GI symptoms. The headache can last 4 to 72 hours. And then after the headache, they don't really feel great. They're still irritable, they're still fatigued. So our patient wouldn't have been as chipper as she was, other than she's anxious to go home. And it's usually less than 24 hours. These are a sampling of the various triggers for migraine. You want to tell people to look at their food. Not all of them will be a problem for them. They just have to recognize which foods bother them and which don't. There are various environmental factors and behavioral and psychological factors. When, for example, insufficient sleep, skipping meals, extra stress at work. So you want to evaluate these factors and make adjustments for them. So what is the pathophysiology of headache? This is a diagram that I drew many years ago, and it's still difficult to really explain the pathophysiology because it's not really well defined. And you have this picture in your handout with more detailed description. But basically there are various headache triggers or various underlying biochemical dysfunctions that lead to a trigeminal nucleus activation. And that then causes a release of a variety of chemicals, and these chemicals cause neurogenic inflammation. And that inflammation is associated with the headache phase. Now, aura doesn't happen in everybody, and that they've attributed to the cortical spreading depression, and that then may also activate the trigeminal nucleus activating system, and that may explain part of the aura phase. And during this pre-phase, there's a decrease in cerebral blood flow, and then as the headache phase comes back, the cerebral blood flow increases. So this vasoconstriction and vasodilation has been part of the theory of explaining the symptoms of headache. There's this change in cerebral blood flow. So we have migraines that are either episodic, that people have 0 to 14 headaches per month, and then chronic migraines are considered more than 15 headache days a month over a 3-month period of time. You need greater than 8 days to meet the criteria of migraine without aura. So what are some non-pharmacological therapies that we can do is we can give them ice and rest, a dark and quiet place, teach them what their triggers are and avoid those triggers, get a regular sleep, eating, and exercise cycle. We can teach them physical therapy and massage to help decrease any stressors or muscle tension aspects of it. We can use ultrasound on the muscles, relax them, acupuncture with various acupuncture points, electrical stimulation in some of the acupuncture points and tight muscles. And we have behavioral interventions such as relaxation, biofeedback, and cognitive therapy. So treating an acute migraine, the goal is to stop the attack is as soon as possible without any recurrences, because sometimes you can have a migraine headache, treat it, and it can reoccur. So that's part of the selection of your triptan, and that's you'll look through the dosing and you'll see that you may have a rebound headache that needs a second follow-up dose. And you want to minimize the need for any kind of rescue medication or frequent use of the acute medication. You want to pick cost-effective treatments and minimize side effects. Using non-pharmacological treatment options is the best because we want people to recognize their triggers and stop these triggers and therefore minimize the need for abortive therapy, because oftentimes people overuse these treatments because they have not recognized their triggers. Like I said before, 80% of the people that were referred to our headache center were because they didn't correct their lifestyle changes first. And again, the earlier you give medication, the better your response is going to be. So our treatment options consist of analgesics, opioids, antiemetics, and a miscellaneous list of drugs that you'll see. And how we select these agents is based on the severity of the symptoms as well as the associated symptoms. And for more severe headaches, we use the ergot alkaloids and the triptans. How do you choose an agent? You look at the side effect profile, you look at the patient's comorbidities, and for less debilitating headaches, we use our over-the-counter NSAIDs and acetaminophen. Sometimes people really like the combination. Some products work better for some versus others. So for example, in terms of the NSAID, some people feel that Motrin works better for them than naproxen. However, our headache specialist likes naproxen better because he feels it's longer acting and there's less chance of people taking extra doses of it. So you have to work with the patient with finding the right drug for them. Generally, acetaminophen doesn't work great by itself, but it's in combination products, and that seems to work pretty well for people. We like to avoid the products that are combined with opioids because we've seen people that use the, like Tylenol with codeine, they have a high risk of the abuse headaches as well, the chronic daily headache. And if the patient has comorbid nausea and vomiting, you want to pick agents where they need like a sub-Q, or if the nausea isn't too bad, the disintegrating tablet where they don't have to drink a lot of water. And you use a stratified approach to treatment like you saw in that patient. Not every headache is going to be a severe headache. So that's why we gave her a selection to pick from. So she'll start with the NSAID, and there'll be a group of headaches that respond well, and then there'll be other headaches where she'll need to follow through with the sumatriptan. So the point is to try to minimize overuse of these medications so that you can give a low potency agent that manages some, and then when she needs a more potent agent, you can use that when you need it. And we have assessment tools called the MIDAS and the HIT, and we can use those to evaluate progress. So again, this is reiterating for infrequent mild headaches, we use the analgesics. For more moderate or severe, we use the triptans and ergots. So we want to be careful about overuse headaches, and it's more common with the opioids, the products that contain butalbital. There's really no value in using butalbital. It basically just puts somebody to sleep. So we don't recommend those agents. The combinations with aspirin, acetaminophen, and caffeine. There are some people that respond well with caffeine, and then there's others where minute amounts of caffeine will aggravate their headaches. So you want to, when you pick that combo product, you really want to know how they respond to caffeine. I used to think that the caffeine-related headaches were really more withdrawal. However, there are some people that are just sensitive to caffeine and can have headaches directly to the caffeine. So what do we do with a person that has medication overuse headaches is we have to detoxify them, and it's not a pleasant experience. It can be done as an outpatient or as an inpatient. So it's better if it's done as an inpatient because they're left in an infusion center where they can get a cocktail of medications over a 24 to 72 hour period, and that's much more supportive. If they're doing it at home, they are going to have a 1 to 2 week period of time of very, very bad headaches, and they're going to be tempted to use the medications. It's not very easy. There are trials where we've tried to put people on prophylactic headache medication as part of the detox, but those medications take several weeks to get to therapeutic effect. So by that time, they've already gotten through the detox phase. So that's why if you have a person that has severe overuse headaches, they're better at some of the headache referral centers where they can be done as an inpatient. So to try to minimize this chronic overuse headache is you want to minimize the use of your abortive medications to less than 10 days per month. So these are our NSAIDs and the mechanism of action related to them. A lot of this is review for you. And we talked about the combination agent already in terms of generally the acetaminophen alone doesn't work great. And metoclopramide, in addition to helping reduce nausea and vomiting, helps decrease the stasis of the GI tract and helps your medications work a little bit better. So now these agents, we have quite a number of triptans. These are all the agents that we have. And I would suggest that you look at the table, the kinetics table in your handouts that compare them. They're listed in the slides as well, but I work better by seeing them all in one chain, all together compared in one table. And the main thing that you might be asked about on board exams is what's different about them in terms of their metabolism and what's different about them in terms of their formulations. Which one do we have sub-Q? Which one do we have a dissolving tablet for? Sumatriptan was the first agent made available, and it has lots of different dosage forms, so it's probably the agent that you've seen the most, but they're all generally pretty similar until you start having repeat needing for repeat doses. Like sumatriptan has a shorter half-life, so you might want to pick ones that have longer half-lives for those that have repeat headaches. And they work by being agonists of serotonin receptors, and they work on vasoconstriction. And you saw, like during the headache phase, you had the vasodilation, and it helps inhibit the release of those peptides that you saw through the trigeminal vascular system. And you base the triptan based on the characteristics of the headache, whether there's nausea and vomiting, how long does the headache last, do they have a second follow-up headache. And just because you fail one triptan doesn't mean you fail the whole class. You can move within the drugs. The class side effects, they're across the board. You're going to see various paresthesias, fatigue, dizziness, flushing, and then what we call a triptan sensation that includes like a tightness or pressure in the neck, throat, and chest. And that's why it's contraindicated in people that have a risk for ischemic heart disease or cerebrovascular disease. So those people are not candidates. So we would not give a triptan for a person with that history. And our patient did not have that. They didn't have uncontrolled hypertension or any of that other history. You do not want to administer if an ergot has been administered within 24 hours. That was on one of the board review questions. And you want to not administer these agents if an MAOI has been in the last 2 weeks. So that's usually not, we don't really use those agents, so it's not that common that you see. And again, these are serotonergic agents, and you want to watch out with giving too much serotonin. You've heard from this class about serotonin syndrome, and these drugs enhance that, so you could also have that as well. So these are the different formulations that you have available. I won't be asking that much in detail, other than that which ones come sub-Q, and so because you want to be able to give that with someone that has a lot of nausea. So they're metabolized by MAO, and they're also metabolized by cytochrome P50, and then there's some that are metabolized by both. So you want to memorize that because that I've seen on the board questions. And these agents that have active metabolites are going to act a little longer. And then the frovatriptan and naratriptan are good for people. Remember, we want longer acting agents for those that have a repeat headache. So if people have a headache, it goes away and they get another one right away. These are a better selection. So you want to know frovatriptan and naratriptan are good for people that have that problem. So these agents have a faster onset, higher efficacy, but they have a higher risk of the headache coming back. And these agents have less. The second class of groups are the ergots. They're not very popular. However, please keep them in mind is in a back pocket. I did have a pharmacy student a number of years ago that had a lot of headaches, and she'd been to a number of centers, and she told me all the list of drugs that she had been on, and she tried everything, but they had not given her an ergot. And so dihydroergotamine is better than ergotamine titrate. It has a little less nausea and vomiting with it. And she tried this, known as DHE. She tried that, and that seemed to work for her. So just remember that in your back pocket as an option. They work by increasing serotonin 1 receptors, and they will cause vasoconstriction as well, and decrease the release of those neurotransmitters through the trigeminal vascular system, and may have some effect on dopamine receptors. So these are a comparison between the agents, and dihydroergotamine surpasses ergotamine, so it's not really a choice anymore between them because it causes less side effects than the ergotamine. Both are contraindicated in renal hepatic failure, and again, people that have cerebral vascular disease, peripheral vascular disease, uncontrolled hypertension. So in terms of opioids, we use these as last resort. They are good for people that are pregnant and can't take the triptans or the ergots, but we usually try to avoid these agents. So we have the antiemetics and miscellaneous drugs that we can use. The metoclopramide, chlorpromazine, I don't know why I don't need to see this. I just want to make sure my computer just switched off, but you have this, so I don't have to worry. Yes, I do. It's not moving forward. I lost the connection here to you. Okay, so we can use, let me just make sure I didn't move forward. Okay, so we have these supplemental agents, and we saw that nausea and vomiting is very common, and that they have added an improvement to helping the headache pain, and as well as the associated symptoms. They block dopamine, and they enhance the response to acetylcholine to the tissues in the GI. So they're good adjunct therapy. So we also can use corticosteroids for those that have chronic status migrainous, which is headache that's lasting more than 72 hours. And it's also helpful some of these agents are helpful in the cocktail. The dexamethasone intranasal lidocaine and IV valproate are helpful for part of the cocktail that we use for taking people off of the chronic abuse headaches for the medications, chronic daily headache. So this is a diagram from your book that talks about how to select the agents. It's a summary of what we said, making sure people are aware of their triggers, and you want to consider the headache severity, and then if they have associated nausea and vomiting. If they're mild or moderate, you go to acetaminophen and NSAIDs. If they're severe, you go more to the triptans and ergots. And then people that are using acute medications too frequently, you want to consider for prophylactic therapy. So what are our choices for prophylaxis? These are to prevent the daily headaches for people that are having frequent headaches still while they're using acute medications, and you've corrected their lifestyle changes. About 38% are candidates for preventative therapy. But we only have about 12% that are actually using preventative therapy. So we have a great option to educate people about this. When do you use preventative therapy? You can use it anytime you want to. They have a list here, but anytime a patient wishes to use it, it's patient preference, they are allowed to use it. The issue is that the list of drugs have a long list of side effects, so a lot of people don't like to use it, so that may be why we have a small percentage using it. But you don't have to use it forever. You can help you break a cycle of headaches. So this is a migraine prevention questionnaire that you can have people fill out, and it helps define whether they're a good candidate for prevention therapy. Our goals are to reduce the migraine frequency, severity, and disability, to reduce the reliance on poorly tolerated acute therapies, improve quality of life, prevent future headaches, and avoid the patient using medication more and more frequently on their own. I keep repeating the same thing because it's a big problem. So the agents that we have are beta-adrenergic agonists, antidepressants, anticonvulsants, NSAIDs, triptans, and some other variety of agents. So the guidelines for which medication to use is based on a lot of the comorbid symptoms that they might have. And you need to give people at least a 2 to 3 month trial to determine whether they're beneficial. And then, you really can tell maximum benefit within 6 months. And then after 6 to 12 months of therapy, you judge the frequency and severity of the headaches, and then you can consider to take them off and try being without it. So these are the agents that through the guidelines have been determined as class A, B, or C, with A being the most effective. And the antiepileptics include valproic acid and topiramate. Beta blockers include metoprolol, propranolol, and timolol. And we use frovatriptan for menstrually related migraines, which is used for a short period of time per month. Backup antidepressants you may see are venlafaxine and other alternative beta blockers and alternative triptans. In terms of other over-the-counter products, an herbal called Butabar was determined to be effective, and NSAIDs and other herbal therapies such as your vitamins and mineral supplements, magnesium, are probably effective. So that's why we told this patient to take a multivitamin, which would have vitamin B and magnesium in them. And they've actually used IV magnesium for people with acute migraines, and it was effective. And these are negative findings. For people that have episodic migraine, in terms of beta blockers, these are the details related to that. Again, propranolol and timolol are FDA approved. We have effective, probably effective, possibly effective. And you want to make sure that you use the selective versus the non-selective. And the trouble people have with this is, what do you think the most common side effect and complaint is. Hypotension. Generally, these people are young and healthy people that have normal blood pressure, and they have a hard time with the drop in blood pressure and the drop in the heart rate. So that's the biggest tolerance problem to it, and it may aggravate depression symptoms in people that have a predisposition. So these are antidepressants. We have amitriptyline and venlafaxine. Venlafaxine is, although it doesn't have great trials, it's a class B, has less anticholinergic side effects than amitriptyline. So that will be used. You have to worry about BPH and glaucoma and serotonin syndrome with your triptans if you're using those frequently. May aggravate, other, if you don't want to use the amitriptyline because it has a lot of anticholinergic side effects. In terms of the anticonvulsants, valproate and topiramate, if you remember from studying for seizures, these agents have a lot of side effects. They have, the topiramate has paresthesias, word finding problems, weight loss, and therefore that, and nausea, so that doesn't go over very well. And valproate has tremors and sedation and menstrual irregularities and weight gain, so that doesn't go over very well. So topiramate is probably used more frequently than the valproate. So you weigh out the pros and cons of each of these agents and you pick the one that matches the patient the best. Okay, so these NSAIDs are used for people that have predictable menstrual cycles, and you initiate them 1 to 2 days before the expected migraine. And naproxen is considered more effective than the ibuprofen, and aspirin is the least effective. And we also can use, if those don't work, we can use robotriptan or naratriptan. So these are some of the alternative agents that we have, and they're worth a try. And in terms of chronic migraine prophylaxis, we talked about this before. We want to avoid the butalbital because it's a barbiturate, and we want to minimize the opioids. Here's a flow diagram from your chart, and it talks about how to select which agent. If a headache occurs in a predictable pattern, like your menstrual cycle, we have the NSAIDs and a triptan. If that's ineffective, you can try beta agonist. If you're healthy and you have hypertension and angina, so again, a beta blocker is good. Calcium channels are less effective, but for some type of headaches, it's worth a try. If they have comorbid depression or insomnia, you look at an antidepressant. If they have comorbid seizure or bipolar disorder, you look at the anticonvulsant. And other agents, you refer to, if they're not effective, you consider referring them to a headache specialist, or you can try combinations of these therapies. That was the case. Did you like the case? So cluster headaches, those are much less frequent. They come in groups, they last weeks to months, that's why they're called a cluster. And it's sudden onset, it peaks within minutes, it often occurs at night, and it seems to be higher risk in the spring or fall. It lasts 3 minutes to 2 hours, and it can have remissions from months to years. Very small prevalence, 0.12%, greater in males, and it usually occurs in the 3rd decade. And there may be a genetic predisposition, and they can be episodic or chronic. Most severe of the primary headaches unilateral, excruciating. It feels like someone's putting a hot poker in their eye. We don't really know the pathophysiology of it, but it might be related to hypothalamic dysfunction or changes in the circadian rhythm or neurogenic inflammation. So the treatment of choice acutely is to give them oxygen or sumatriptan, and we do oxygen 12 to 15 liters per minute, 12 liters per minute for about 15 to 30 minutes. You can do the nasal spray with the sumatriptan. The oral agents probably won't work fast enough. And there's no good clinical trials with that support the ergots. However, we have used IV DHE, and we've used sublingual and rectal forms of ergot. Again, DHE is going to be preferred. For people that have repeat episodes and you want preventative therapy, calcium channel verapamil has been tried in adjunctive and second line with lithium or steroids. Tension headaches, everybody's had those, right? How many have one now? It's early in the morning and close to finals. The most common type, this is the most common type of headache. It's going to peak in your 40s, more common in women, and then it starts to decrease as you get older after that. It often can go coexisting with migraines, people that have sleep problems. They find that people that aren't married have a higher risk of that. And so just being happy and good lifestyle is good. Episodic is if you have less than one headache a month. That's the majority of the population. Frequent episodic is 1 to 4 per month, and that's about 22% of the population. And more than 15 headaches is chronic, and that's less than like around 2% of the population. They don't have any aura preceding. If the headache is dull, it's not pulsatile, and it feels like a tight pressure. It's usually bilateral, more common in the front in the temporal areas, but it also may affect the occipital and parietal. It feels like a hat band to most people, like a pressure device. It's recognized as its own disorder and may be aggravated by other myofascial disorders like muscle tension, stress. And so there are techniques where we can teach people myofascial release. There's different relaxation techniques. They probably do well with massage and yoga and other ways to reduce stress. Cognitive behavioral therapy has been used to help with them with stress management, training, relaxation, biofeedback. These can be used in combination. Giving them supportive treatment with cold packs, ultrasound to relax some of the muscles, electrical nerve stimulation to relax the muscles, giving them stretching, exercises, massage, acupuncture are all helpful. And recognizing triggers to what aggravates your headaches. They respond to NSAIDs and acetaminophen. And some people may need preventative treatment. They may have associated symptoms of depression. So those are useful, and you want to look to see these agents based on if they have sleep issues, like mirtazapine is very sleepy. And amitriptyline is what's listed in the guidelines as being effective, but again, we usually try to avoid it because of the anticholinergic properties. And these are defining it as chronic. And that's it. Got done a little early. Do we have questions? Do you want me to show the dementia videos, or do you want to break and watch them at home? How many want to watch them now? So how many want to watch them later? Okay. All right. Any questions before exams for me? I have a good amount of material on the final. Anything to review? All of these drugs have a lot of side effects and drug interactions, and what I try to do in class is to, organize the material for you. And a lot of the handouts the students tell me when they go on rotations have been very helpful. So that's why I've given you the extra material, or if the case discussions. So that's why the supplements are for you to guide you, and you can look at the sample study questions and look at what we covered in